very good morning, ladies and gentlemen. Thank you very much for joining us this morning and welcome to our webinar on common urological conditions and their treatments. My name is Dr. Yongjin, the organizing chair of the seminar today and also your host. The Department of Urology, Singapore General Hospital is celebrating our 35th anniversary this year. As part of celebrations, we have organized this free webinar to educate the general public about common urological conditions and their treatment. We are very heartened by the response and thank you very much for your support. We have a series of informative talks lined up in both English and Mandarin today. You will also have an opportunity to post questions to the speakers in the Q&A chat box, and we will try to answer as many of them as possible. Our department is also raising funds to support cutting-edge urological research and education in SGH. We will share how you can donate to this very worthy cause at the end of the webinar, and we thank you in advance for your generous support. Without any further ado, it is my pleasure to invite our head of department, Senior Consultant, Associate Professor John Yuan, to deliver our opening address. Professor Yuan, please.
Okay, my slide is up. Okay, thank you very much. Thank you very much, Yongjin, for starting the webinar this morning. As Yongjin said, this year is a special year for SGH Urology as we celebrate the 35th anniversary of the founding of our department. We are not only the oldest urology department in this country, we are also the largest, probably not only in this country, probably in this region as well. Can I have the next slide? Okay, next one. So we have seen grown from strength to strength. We are now a department consists of 15 specialist urologists. You recognize some of the very familiar faces. Next one. So these specialists provide a very comprehensive range of urological specialist service, from treating stone to cancer, kidney transplant, female urology. We are also known to be the pioneer in the robotic and keyhole surgery in this part of the world. In fact, we are the first department that performed a robotic surgery in Asia. That was about 20 years ago. Next slide. Okay, and we continue to improve our service, and also we continue to expand. Just last month, we launched a new service center, the Prostate Center in SGH. And this center will provide a one-stop service for a very comprehensive diagnosis and management of all prostate problems. Men that suffer with all kinds of prostate problems will be treated in the prostate center. Next one. And the commonest prostate problem affecting men is benign prostatic hyperplasia, or the non-cancerous prostatic enlargement that cause obstruction to urinary flow. In fact, next one. Through the work of our founding father, Professor Fu, and Associate Professor Ng Lek Wat and Dr. Edwin, the two speaker features today, just to name a few, we are really the pioneer in the diagnosis and management of prostate enlargement. And you're going to hear the first two speakers talking about prostatic enlargement, how we diagnose them, and how we manage the problem, and how we offer the latest treatment. Next one. So this webinar also touched on the touchy topic of prostate cancer. I'm sure most of you are very interested and keen to learn more about prostate cancer. Next one. Prostate cancer is a very common disease. You may recognize the faces of some of these men here. They are not only very famous men, some of them are very powerful and wealthy. They also have one thing in common: they have prostate cancer. So prostate cancer is quite common. It's one of the top 3 cancers affecting men in Singapore. Dr. Tan Yu Kwang is going to tell you about the diagnosis and further management of men with prostate cancer. So we look forward to that. Next one. So in fact, we are the department that offers the most comprehensive diagnosis and treatment options for prostate cancer, not only in Singapore, but in this part of the world. So if you come to us, you probably have a one-stop service for diagnosis and also subsequently for treatment of prostate cancer. There are a few options for prostate cancer treatment. For minimally invasive ablative treatment, we call it using cryotherapy, to robotic surgery, to radiation surgery, and we offer them all in SGH. Next one. So this is the agenda of the talk today. You're going to have three very good speakers talking about prostate enlargement and prostate cancer. And without further ado, I let them start the talk. But last but not least, next one. I would want to thank everybody, all in the public, for all your support throughout the years. And only through your support to SGH Urology in whatever way, by attending the talk, by donations, by coming to see us, you make us one of the best urology department in the world, and that has been recognized in a survey by Newsweek. So we can't achieve that without your support, and I hope to continue to receive your support to SGH Urology, and in return, we promise to improve on our service and to do better to serve you. Okay, thank you very much, and I'm so glad that we have more than 1,000 of you who register. In fact, almost 700 of you have already logged in, and I'm going to see more and more people log in throughout this evening. And a very big thank you to everybody, and a very big thank you to all the speakers and Yongjin for making this today event possible. Okay, over to you, Yongjin.
Thank you very much, Prof. Ian, for that introduction of our department and our work. May I introduce our first speaker for today, who will be speaking about a very common urological complaint, lower urine tract symptoms, and also nocturia, which is basically having to wake up at night to pass urine. Dr. Lim Yi-jin is an associate consultant in the Department of Urology, Singapore General Hospital. She receives a basic medical degree from the University College London and subsequently Master of Medicine Surgery from NUS. And she was also elected a member of the Royal College of Surgeons of Edinburgh. She has also earned her MPH in Health Policy and Management from Berkeley Public Health in 2020. Dr. Lim has a keen interest in benign prostatic diseases and also in renal transplant. Please welcome Dr. Lim Yi-jin, please.
Hi, good morning. Thanks, Yongjin, for the kind introduction. Let me just share my slides. Okay, good morning. Thanks, Yongjin, again for the kind introduction. It is my pleasure to kickstart this series of exciting webinars that our department has planned this morning. I'm happy to see so many people tuned in. So I will start off my talk with an overview of lower urinary tract symptoms and go through nocturia in a nutshell. As Yongjin has said before, it's extremely common and affects a large proportion of patients, meaning the public like yourselves. So this is basically to equip everyone with some basic knowledge and set the stage for subsequent webinars. So the outline of my talk will briefly be about the lower urinary tract anatomy and its associated common symptoms. The importance of being able to accurately describe your symptom to us will really help us in trying to see how to proceed to diagnose and to manage you with the correct therapy to then achieve control of your symptoms and better quality of life. We'll then go on to nocturia in a nutshell. So we'll start off. Firstly, this is the urinary tract. Okay, the kidneys produce urine. It travels down the ureter, which is very thin tubes that connects the kidney to the bladder. The bladder then stores the urine until you have the appropriate urge to void. So the upper tract will consist of the kidneys and the ureter. The lower tract, which is what we're focused on today, is mainly looking at the bladder and the urethra. And of course, in men, there's the prostate. So there's some differences in the male and female lower urinary tract. On the left is the female tract. As you can see, the urethral length is much shorter and the continence is usually maintained in the sphincter, as well as the bladder neck and pelvic floor muscles. And on the right in the males, you can see the difference is mainly the prostate, which all men will have, and it sits at the opening of the bladder. As you can imagine, this not only lengthens the urethra, but can be a potential source of resistance and obstruction when it enlarges. And also because the penile urethra is much longer, there's a lot of opportunities for narrowing along this narrow tube, which then lead to strictures and increased resistance. So both also have a sphincter and a bladder neck, which plays an important part in continence. So how do you void or how do you pee? So firstly, I think it's important to note that the whole circuit will include the control centers in the brain, which is number one, and the spine, number two. This is very crucial in coordinating the complex sensory information that it receives and how it then sends impulses to the bladder and sphincter via the peripheral nervous system, which is 3. So I mentioned this because the whole circuit has to work in perfect tandem to coordinate the whole voiding process. And if there's any problems or insults to any part of the system, it can affect any step of you peeing or voiding. So this is a very simple pictorial representation of the lower urinary tract, showing the bladder and sphincter. The prostate is just not demonstrated here. It's mainly for just explaining. So the first phase is basically including filling and storage phase. So during this phase, the urine starts accumulating and is stored in the bladder. The bladder muscle is relaxed. The sphincter keeps contracted. This then stretches the bladder muscle and sends continuous information to the bladder. It sends continuous information to the spinal cord up to the brain for processing, which keeps the bladder relaxed to allow more filling and sphincter contracted for continence. So when it feels enough, you then feel the urge to pee. The brain gets this information, and then you initiate the urge to pee. So there's a complex interplay of instructions that's given to the nervous system to tell the bladder muscle to start contracting, to then relax the sphincter, which then the urine can pass out. So all this has to work in tandem and synchrony to allow smooth passage of urine. We will then come back to this later. So what is LUTS, or lower urinary tract symptoms? It is actually the commonest presentation in urology and what we see in clinic and what you bring to us for us to help you with. It's also what you find the most bothersome. Okay, so peeing consists of both voiding and storage symptoms. It is an umbrella term, okay, for a large variety of symptoms, we can be classified into both storage and voiding post-maturation. So the storage symptoms will include urgency and its associated urinary incontinence, increased daytime frequency, so many go many times, and Nocturia, which is getting up at night. We'll talk about it later. There are also voiding symptoms, which will be mainly associated with outflow resistance or the inability to contract the bladder. So this mainly gives you hesitancy. So mainly you wait quite long before you want to start. Intermittency, so a start, stop pattern. A slow stream, which can mean the very fine stream, very narrow, and terminal dribbling, so you drip after you pee. So this tends to be a little bit more prominent in males because of the prostate and the longer urethra. But it's also to say that it's not exclusively males. Females can also be affected if there's any form of obstruction, such as organ prolapse, or urethral, meaning the opening that is narrowed or stenosed due to atrophy after menopause. So going back to this pictorial again, as I mentioned before, the whole process is controlled by the brain and spine. So any condition affects that these two can also affect the control. So for example, in the brain, dementia, stroke, quite common. In the spine, if you have any prolapse disc, any prior injury, and the peripheral nervous system. So these things can affect like diabetes, if it's poorly controlled, or vascular disease. These can affect the very small nerves that control both the sensory and the motor. So meaning the sensation and how you contract your bladder and relaxation of the sphincter. It can range from a spectrum for basically over sensation, so hypersensitivity, which is you overactive, or insensate, so meaning something that you don't feel, lead you to retention symptoms. So the other thing to keep in mind is also abdominal surgery. So anybody who has colon cancer, cervical cancer, you've had previous operation or radiation, this can also affect the nerves that travel to the bladder. And this affects sensation as well as how you pee. So it's very hard to pinpoint exactly how all these contributes to you having trouble passing urine, and it's variable response depending on the extent of your recovery and rehab. So the other causes commonly will be things like if there's any bladder, anything inside the bladder, for example, bladder tumor, a bladder stone can give you bladder irritation and storage symptoms. If there's ongoing infection, either in the urethra, the prostate, or the bladder, this can give some also irritative symptoms. So voiding symptoms, if your bladder cannot contract, or if there's resistance on outflow, enlarged prostate, which I think my colleague will talk about later, any stricture due to injury or infection, or even simply just a very tight foreskin just before your urine exits. So these are the simple things that we can rule out first before diving deep in. So a quick slide for females, as I mentioned before, it can also affect them. So basically, commonly will be things, for example, womb prolapse, meaning your cervix or your womb, due to pelvic floor weakness, starts to slip out. And when it slips out, you can see the picture on the left, it presses against the urethra. And this can be some form of resistance, making it hard for you to pee and giving you lower urinary tract symptoms. The other spectrum will be stress incontinence. So your pelvic floor muscles have been damaged by vaginal delivery, either via the pressure or previous nerve damage. And this makes the pelvic floor very weak. Therefore, any kind of increased pressure, like coughing, running, can give you a little bit of stress incontinence when there's pressure exerted on the bladder. Okay, so how do we start investigation? I mean, after you tell us your symptoms, we'll do a very thorough physical examination. Okay, we'll check the tummy, the abdomen for any distended or full bladder, which could suggest that you can't pee out completely. We also check the urinary tract, so things like the genitalia in males, check the penis, the foreskin that I mentioned. We also need to check the prostate, okay, which we put a finger up the back passage or the rectum. And I have some patients asking me why I have to check the rectum. It's mainly because it's very close relation of the anatomy, and this is quite essential in the initial investigation. So after the examination, we'll do basic investigations. So simple things being simple, we'll do a urine test to check for any infection, okay? And then we'll also do a uroflow test. So this is actually quite simple, gives us quite a lot of information. Essentially what you'll do, you'll be asked to pee into a small funnel with a pot. So the females will be sitting and the males will be standing, okay? This translates into a curve we can read. And what this tells us actually is one, how much you can pee you can store, the maximum flow rate in the shape, and also how long a length of time you take to pee. And lastly, after this test is done, you come back and we'll check how much urine you have left. Okay, yeah, so this is a typical pattern. I won't go too much into this, but it's something that we can do. It's important to note that when we ask you to do this test, we want to mimic a typical episode of when you want to go to the toilet. So not too full and not too empty. We just want to see the typical flow. Okay, so these are, I mean, some of the typical patterns that can help us in leaning towards what kind of pathology we think it is. So for example, if there's a lot of like peaks, you can see there's a lot of straining, it might mean there's some kind of resistance or incoordination. On the right, if you can see, it's very long and flat. It takes very long, so meaning the outflow might be very narrow and very thin, or the bladder cannot contract very well. So these are some useful patterns we can do. Okay. Now, the next investigation as well, we're going to talk about will be the bladder voiding diary. Now, I cannot emphasize how important it is. It can be tedious for the patient to do, the public yourself to do, but it's extremely useful, and it's one of the non-invasive tests. So we'll give you a chart, as you can see on the right, and we'll ask you to record down the amount and type of fluid you intake in relation to how much you pass out over 3 days and 3 nights. So this is a zoom in version. You can see over the columns is 3 days, okay, and the time, the fluid pass, and the urine. So it's a bit tedious, but for the patients who manage to complete it and bring it for us to review, it actually really helps in how to proceed and optimize your medical therapy. There are also some patients who tell me that after they do it, there's a little bit of self-reflection to adjust some of their intake, which also helps them themselves. So main things you can see, we're looking at the type of fluid, the time you drink, how much you pee and when. It's also good to note down when you wake up. So the asterisk on the bottom is when you sleep and when you wake up, because this can help us know how many times you get up at night in between your sleep period to pee, which is important in Nocturia, which we'll go through later. You can also write down if there's any times of urgency and leak. Okay, so it's simple enough, but it gives us some information. So this is an example of one of my patients who actually made the effort to do it. And you can see, okay, on the blue arrow, just before he sleeps, he drinks about 250, which means that it's quite likely he will have to get up once at night. And the small orange arrows on the right, okay, small frequent voids of 50 and 80. Okay, so his main complaint was that he goes to the toilet very often. And you can see it's very small amounts, and this can be suggestive of overactive bladder. So with just this simple recording, we have come out with a very likely diagnosis. We can help you medicate. So moving on, we'll do some basic blood tests, okay, like PSA. I think my colleague Yu Guang will go on later, but only in males, okay. Kidney function, renal function, there are some blood tests we can do, but it's not routine. So mainly we only do it if we suspect any severe obstruction. Lastly, we can see us doing in clinic will be some bedside ultrasound. This is a very simple, non-invasive as well, mainly to check the kidneys. It's a screening, okay, to check the kidneys for any swelling, hydronephrosis, which might suggest chronic obstruction. We can also see sometimes large obvious bladder stones. We'll measure the prostate volume and the size, which can also help in your diagnosis. So tying it all together, LUTS, LUTS, or lower urinary tract symptoms, is a large umbrella of terms, and there are endless causes. We will investigate, treat the cause if possible. Most of the time, it's not just one cause, and we will just have to go accordingly and treat what mainly bothers you. either one specific symptom or combination of all. So it's important for you, the public, to participate and join us with a shared discussion for decision making. The second part, we'll move on to talk about nocturia in a nutshell. Now, as Dr. Yonji mentioned before, it is very common and it's usually the most bothersome symptom that patients come in to tell us. Simply put, it is waking to pass urine during the main sleeping period. Okay, the number of times that you pass urine during the sleep period must be preceded by sleep and the intention to go to sleep. So the difference, why I highlight this is basically there's a difference in the patients who can't sleep. And then they say that, oh, they can't sleep, so they get up, start drinking water, and then they feel like they want to go to pee. Okay, so how do we measure this? So once again, it's the bladder diary. Okay, there's a quick slide on how common it is. Okay, this is a local study published. You can see it's very common. More than 55% of patients actually come out more than once at night to pee. It goes down a bit more, 20%, about 2 times. You can see on the right, the graph, it shows that the prevalence of nocturia actually increases with age. Okay, so what are the risks? Of course, we are worried, right? Because you wake up at night to pee. Firstly, we're worried about you fall down at night. Okay, when you're sleepy, when you wake up, you have giddiness as well. You can be a bit disorientated. And this is actually even more worrying in patients who are older. Okay, daytime function can be impaired. So I have a lot of patients who come in telling me they can't concentrate, they can't function well because they can't sleep at night. There's also some association with increased mortality. So meaning associated with heart disease, diabetes, and stroke. So what causes nocturia? There are many, many causes. Okay, there's a nice chart showing various causes, which we'll go through. We want to emphasize that the actual urological causes are only a small proportion of the reasons. Okay, for example, the red box. There are actually many, many other causes, medical diseases, such as heart failure, adjustments in hormone production due to age that affects water production at night, as well as sleep disorders. Okay, so it's important to know that when usually they come and present to us in clinics because that's what people feel, but we have to take a deeper look as to what causes this problem. So I think largely classify the reasons why. The first one will be mainly increase in urine production. Okay, so total urine production, which is global polyuria over the entire day, over 24 hours. Okay, the second will be increase in urine production, but only at night. And this is nocturnal polyuria. There's only a small proportion, as I mentioned, due to urological causes. And this can be due to bladder storage disorders that can be secondary to obstruction, such as overactive bladder, enlarged prostate, or organ prolapse. Essentially, you have some lower tract symptoms that basically make you hard to void, or your bladder can't store very much. That's why you keep getting the urge to wake up and pee at night. And lastly, as I mentioned before, sleep disorders. So we'll go straight into global polyuria, so meaning increase in total urine production. This is across the entire day. The medical definition will be more than 40 mL per kilo per hour. And how do you know this? It's also via the bladder volume chart. Okay, so you know how much you pee out over 24 hours. Now, what are the causes? Commonly will be diabetes. Okay, some patients will present with a new diagnosis of impending diabetes. This is because the sugar or high sugars in your blood levels will basically ask you to draw water, and then you are having to pee more. But also quite commonly that people don't realize is primary polydipsia, which is habitually increased fluid intake. So this is an example of a bladder volume chart. As you can see, the patient tells me in the blue box, okay, from 7 onwards, he starts drinking a lot of water before sleep because someone told him that it prevents heart attack and stroke. So you add it all up, adds up to about 1 liter before bed. So he doesn't even realize it until he did the chart. So it's quite simple. What goes in must come out. Your bladder cannot store so much at night. So you will definitely get up to pee at night if you drink 1 liter before you sleep. So the simple solution will be don't drink before you sleep. Adjust your fluid intake earlier in the day so that you can empty your bladder before you sleep. So the next will be nocturnal polyuria, and this will be increased urine production mainly at night. Yeah, so we're not exactly too clear about how and why it happens, but it's related to age. Okay, when people age, the hormone, antidiuretic hormone responsible for water reabsorption, becomes deficient at night. Therefore, if the water is not reabsorbed, it then comes out in the urine. And this condition usually can be medicated. Okay, the medical definition will be more than 20% of your overall urine output if you're less than 65 years, and more than 30% of your 24 urine output if you're more than 65 years. Now, this also is diagnosed via the bladder volume diary. Yeah, the blue portion below is what I want to emphasize as well. not just hormone production, which is something that we can treat. The other things are equally important, actually more common, and they are usually non-urological. Okay, so things like edematous states, so water retention, the layperson, lower limb swelling. This can be related to heart problems, kidney problems, liver problems. It's basically pooling of the excess water in your extremities and your legs. Obstructive sleep apnea, you snore at night. Alcohol, caffeine, this affects bladder sensitivity, basically irritates the bladder. So if you drink it after 12 o'clock in noontime or anytime in the afternoon, the effect usually kicks in at night. And it also draws water, so it's a diuretic, which makes you produce a lot more urine at night. So you'll definitely have to get up at night to pee. Of course, any other chronic medication, so patients who have heart failure, they'll be on water tablets to help you dry out. You can try to adjust and discuss with the heart doctor to shift it earlier in the day so that the water doesn't get produced or your urine doesn't get produced at night. Okay, so as previously said, obstructive sleep apnea, actually very common. Now, spouses will usually complain of loud snoring, choking, gasping for air. This is mainly due to the relaxed tongue muscle falling back to block the airway at night, which then affects the hormone, which controls water regulation. The management will be actually a referral to the ear, nose, and throat specialist, and we'll usually suggest for CPAP or some kind of surgery. It's important to note that this can affect both men and women, and it's actually quite useful to get it treated, which will really help your nocturia at night. As I mentioned before, it's also crucial to ensure it's not a sleep disorder, meaning you're unable to sleep well, hence you keep getting up, thinking, and then drinking water, and then going to pass urine. And lastly, swelling in the legs. Okay, so if you notice that your legs are a little bit swollen, either you're standing too long in the day or you have some mild heart disease, if you lie down, okay, your legs after a while will return back to its normal size. And this is because the water that's there is returned back to the heart, is then pumped to the kidneys, is then filtered out. So therefore, you produce more urine. So you lie down at night, if your legs are swollen, the amount of water will likely translate into the urine, which you will have to get up at night. So what can you do? Basically, you raise your legs much earlier before bed. So ensure they're not so swollen before you go to sleep. So this is an example of a bladder chart. I mean, this one of the patients was very tech savvy, and then he took the form and made it electronic and came out of an Excel sheet. So you can see it's a very nice pattern. The lines represent one day, okay, and the intake. He doesn't drink a lot, but he does drink when he wakes up and pee, at least on the first day. And you can see the red one that I've highlighted is the amount of time he pees at night, not just the times, but as well as the amount. And you can see it's definitely more than 50 to 60% of his overall daily urine output. So on the second day, he realized that he was also drinking water when he woke up, so he cut that down. And despite that, actually, he still produces quite a lot of urine at night. So this will be the diagnosis of idiopathic nocturnal polyuria. So the main question for this is, one, does it really bother you? Okay, on one hand, I have some patients who are working the day. They find it very hard to concentrate because they keep waking up, very hard to fall asleep. Yet on the other hand, I have a spectrum of retirees, they just want to know that nothing is very serious, there's no cancer. They're happy to sleep in a bit more in the morning or rest in the afternoon. Okay, so this is something that we'll look at when you come to find us in clinic for this problem. So things you can do, as I said before, you try and limit your fluids before bedtime, especially caffeine and alcohol. Increases your hypersensitivity of your bladder, produces more urine. The other simple thing would be to try double voiding. Okay, this is to urinate. So you get up, you pee, you wait a few seconds, and then you attempt again. This is to allow maximum emptying of the bladder, so your bladder is empty, and delays the time for which you feel the urge to pee again the next time. It's also very important to manage the underlying conditions, diabetes, heart failure, sleep apnea, as I said before. Okay, the reason I say this is because sometimes I have some patients who come back a few times and then I suggest to them to go and see some other specialists, and they're like, oh, but this is a urinary problem, I can't adjust this. So I think it's good to have an overall view to see how other things can affect as well. Okay, things like stroke and all the other conditions, not just the urine that you produce. Okay, so in summary, the take-home messages. LUTS, lower urinary tract symptoms, is a complex group of symptoms that patients will present with and what you come to find us for, mainly because it's very bothersome. There are many causes with no one magic pill. We will need to evaluate all causes and treat the treatable ones, okay, for relief of the most bothersome symptom or even in combination. Okay, nocturia is very bothersome and it does affect a lot of people. Okay, there are many causes as well, and it mainly is non-urological. So do not be so puzzled or some things that we ask you. Basically, we want to refer you to our other specialist colleagues, such as ENT, the endocrine doctor for better control of your diabetes, or heart doctors for your heart failure. So I've already emphasized the importance and simplicity of the bladder volume diary, which will greatly help in management. So the management will really depend on how it impacts your quality of life. Okay, so this concludes the segment of my webinar, my segment of the webinar, and I thank you for your kind attention. I think there'll be a Q&A later. Okay.
Thank you very much, Dr. Lim, for that very informative talk. And I think we have all learned a little bit about lower urinary tract symptoms. There's a lot of activity going on in the Q&A. Please keep that coming. If you have any questions, please feel free to enter them into the Q&A chat box and we'll try our best to answer them. Okay, to build on what Dr. Lim has shared with us, may I introduce our second speaker for today, Dr. Edwin Jonathan Aslim. Dr. Edwin is consultant urologist in the Department of Urology in SGH. He graduated from the University of London in the United Kingdom in 2009 and returned to Singapore to complete his specialist training in urology in 2019. Dr. Edwin has a special interest in kidney transplantation, kidney surgery, and benign prostatic diseases. He is currently the Director of BPH Services in SGH Urology. Please give a warm welcome to Dr. Edwin, please.
Okay, hi, good morning, everyone. Okay, so today I'm going to talk about a little bit about benign prostate enlargement. Let me just share my screen. Okay, I hope you can all hear me. Okay, so let's get going. So I'm going to talk about prostate enlargement in a nutshell. So this is the outline of my talk. I'm going to talk about a little bit about basic concepts. There will be some overlaps with what Dr. Lim has had discussed earlier on. And I'm going to discuss about what are the treatment options available for benign prostate enlargement and when a man should consider surgery. Okay, so some basic concepts. So the lower urinary tract, as what Dr. Eugene has mentioned earlier on, is composed mainly in a man of the bladder and of the prostate, and of course all the surrounding structures like the supporting tissues, the organs, and the muscles. So what are the functions for the bladder? So mainly twofold. One, it is a reservoir for the storage of urine when you are not expelling it out, and it also acts as a pump. So it is a muscular organ as a pump to expel urine when the need arises and at command. And the prostate, there are some functions of the prostate also. It is not an entirely expandable organ as some men may like to believe. Important functions, including sexual functions, it is involved in a small amount of semen production. It contributes to a small amount of your semen production. And it is also an important organ for a normal ejaculation. What I mean by normal is the forward flow of the semen rather than flowing backwards. One of the other important function is also to maintain continence, that is to prevent urinary leakage at normal situations, at normal times. So in benign prostate enlargement, what we medically term as BPH, benign prostate hyperplasia, there is an enlargement of the prostate that distorts the urinary outflow. This is an age-related, non-cancerous condition, enlargement of the prostate. It is very common. It affects up to 50% of men by the time they are 50 years old. But of course, not all these men would require treatment. This is the typical age where the prostate starts to enlarge, and you may notice some changes in your urine flow that is not, that is different from how it was, say, 10 years ago. But you may not need to have any treatment at this point in time because it is not yet bothersome enough or problematic enough for you. And this enlargement then distorts the outflow of the bladder, and this results in the lower urinary tract symptoms of all sorts. So if you can see the normal bladder outlets on this image, you can see the bladder neck is open, it is funnel in shape. The prostate channel is open. Now, if you compare this to a prostate that is enlarged and a bladder outlet of a BPH patient, you can see the bladder is closed, especially if the enlargement is bad enough to distort the bladder neck and causing to be raised and shut. This can certainly impact the flow. The other thing is the prostate channel is also distorted and closed as it is being impinged by the nodular enlargement of the prostate. So the lower urinary symptoms are typically caused by changes in the pressure balance between the bladder and the outlet. So when the outlet pressure is really high, then the bladder pressure has to increase also to compensate so that the man is able to overcome the outlet pressure to pee properly. But over time, this can result in a cumulative damage to the bladder, which may not be entirely reversible if this goes on for a long time. So what I mean by that? So in a patient with a prostate obstruction or blockage, so the bladder has to push the urine out against the resistance so that you can have some kind of a normal flow. So at the early stage of a long-standing blockage, the bladder muscles start to thicken. So at this point, you may not notice a very significant drop in the urine flow because the bladder is still strong enough to really push the urine out. And some patients may even experience a normal flow, but that is not necessarily a normal situation. That may be that man may have what we call a high pressure voiding. If you leave it long enough without any treatment, the bladder starts to overcompensate. It is now thickened and the muscle fibers inside becomes abnormal. You have high pressure urination, and some patients may start to experience abnormal bladder contractions or spasm. So what they experience, they may have to go to toilet more often. Some of them, if severe enough, may experience urgency. They're difficult to postpone the urination, and some of them may even have incontinence. So before they reach the toilet, it starts to leak up a little bit. And if you leave this problem for a long time without any treatment, eventually the bladder is going to fail, and this is a stage 3 of the bladder changes, where there is a loss of bladder strength, and the bladder at this point in time will not be able to empty adequately anymore. So what does it look like if, let's say, we are going to do a cystoscopy, put a camera in the bladder, and we have a look at a normal patient and one that is at stage 3? This is what it's going to look like. The top one shows a normal bladder, very smooth skin of the bladder, the mucosa of the bladder, what you call the skin, and very nice blood vessels flowing through it. The blood vessel supplies the skin of the bladder. In a end-stage bladder, you can see below, the muscle is abnormally thickened. It looks like a bird's nest there. And you can see the skin of the bladder is also abnormal. It's very pale. There's a lack of blood flow through it. And over time, you can just imagine that this is not, even as a layman, you can imagine at this stage, the bladder function is going to be, there will be some irreversible component at this point in time. Okay, but from normal to reach this stage, you have to leave it alone without any treatment for a long time. And this can be avoided. The progression to this stage can be avoided with adequate and early treatment. So as a basic assessment, when a man comes in complaining of a lower urinary tract symptoms, there are a few things that we want to ask. We want to make sure that this is not a bladder problem. We want to explore that this is not something that we need to worry about, like a prostate cancer. But as a basic, we measure 3 things. One is how severe are the symptoms, how bad is it? So we may ask you to do some questionnaires when you come to our clinic. We also want to measure the urine flow. This is the objective way for us to see how bad your blockage is. So Dr. Ejin earlier on has showed you what the uroflow looks like. And we also want to measure your prostate size and also the shape. This is done by an ultrasound that we do at the clinic setting. We also need to routinely check to make sure that we are not missing a prostate cancer. So we will routinely do what we call a digital rectal examination, just to have a quick feel of the prostate through the back end. And at the same time, we will send off some simple blood tests, which you do not need to fast for, to check for your PSA, which is your prostate-specific antigen. Dr. Tan Yu Kwang, the next speaker, will talk a lot in greater detail on this. There are also other variations of these tests. If some of you may have gone for such tests, for example, like PHI with the prostate health index, we don't routinely do that test in SGH here, and I will leave it to Dr. Tan to explain a little bit more. Okay, so what are the treatment options available? Generally, we classify into three. Conservative for the really mild symptoms. For example, for the young man who have only started to have some of these symptoms, but it is not too bad, and doesn't want to have any medications at this point in time, I think it is still safe for us to treat it conservatively, meaning no medications. We just take some lifestyle changes to help with the symptoms. And if that doesn't help, some of these patients may eventually require medications as the first line, which is what we always offer first before we proceed to surgery. So conservative treatment, it basically involves really logical advice. First thing, avoid triggers. What are the triggers? Excessive caffeine, because it can irritate, or not irritate, it can make your bladder more sensitive. And also it induces a diuresis, meaning it makes your kidney squeeze out more urine. Some certain kind of flu medications, it can also slow down the urine flow by tightening the muscles around the prostate. So if you have a little bit, for those men who are predisposed to slow flow and has some baseline prostate enlargement, try to avoid flu medications if you don't need it. Of course, if your flu symptoms are really bad, you have no choice but to take some of these things. But these medications are known to cause urinary retention for patients with large prostates, especially when they're a little bit older. Correcting bad habits. Some patients, I see quite a lot of patients because of their work, for example, drivers, taxi drivers, they have no choice but to postpone the urination for long periods of times. Over time, this can cause some damage to the bladder. They can end up with a bladder that is over responsive, end up having to go to toilet very often. So some of these habits, if you can, please correct it. Excessive fluids, excessive caffeine, and excessive alcohol before sleep. These are also bad habits that you can correct to improve your urinary symptoms. And finally, logical fluid management. Patients tend to be advised by other people, whether it's medical professionals or not, to take lots of fluids, and some of them take excessive amounts of fluids throughout the day, which includes the evening time. So I mean, you are feel free to drink as much as you want in the day if you would like to, but in the evening at least try and cut down some of the fluids so that you can have a proper sleep. Sleep is important, because if you don't have enough sleep, then it starts to affect your performance, and it can be unsafe for those patients who do not have enough sleep throughout the night. And so try to avoid excessive fluids in the evening before sleep. Typically about 2 hours before sleep. You can stretch it up to 3 hours. That usually helps a lot. And finally, reduce soft intake, and this has been shown to reduce the nighttime urination in men. Okay, medications. There are quite a number of medications available. As a first line for prostate medicine, we usually give two. These are our workhorses medications. The first one is an alpha blocker. I will come to that in a while in more detail. The second one is a 5-alpha reductase inhibitor. Then in special circumstances, for example, in men who also have a coexisting bladder problem, sensitive bladder, we can add on overactive bladder medications, or for men with a little bit of erectile dysfunction, we can add on some medications also to help with the erection. Alpha blocker, a few examples like tamsulosin, alfuzosin, terazosin. In some other countries, telodocin is quite popular. It works by relaxing the smooth muscle around the prostate and the bladder neck, so that where you reduce the resistance of the bladder outlet, so that when you pass urine, the urine is easier to pass and with a faster flow. Some of the common side effects: blocked nose, because your smooth muscle is also present in your blood, in your major blood vessels. Some patients who are susceptible, who are more sensitive, they can get a drop in the blood pressure and experience some giddiness. But usually that lasts for a few days, and your body will adjust to it and it'll be okay. But it's a small subset of patients who are really sensitive. They can get a lot of drop in the blood pressure. That's when, they can start to experience almost like a blackout. For example, they sit for a long time, when they try to stand up, they feel like they're going to faint. So that is not safe. You are too sensitive. You have to stop it. It can cause some degree of lethargy, and commonly it can also cause abnormal ejaculation. doesn't affect the orgasm, but some men may experience shooting blanks, nothing coming out. So this is what we call the retrograde ejaculation, the semen flow backwards instead of forwards. Not harmful to health, but if you are still in the stage that you want to try to expand your family, it's not a good idea. And it can cause problems with that. 5-alpha reductase inhibitors. Examples include finasteride, which is also used for hair loss at a lower dose, and dutasteride. So it acts on certain hormone receptors in the body tissues, especially in the prostate. So it reduces the prostate size over time, but you have to take it for a long time, and a minimum take it for 6 months or so before you experience about 20% reduction in size maximally. You can't get anything more than that. So it is a subtle reduction in size, but often this is helpful enough to improve the flow over time and to delay the need for BPH related surgery. The side effects, the chief side effects is erectile dysfunction. It really can cause some problems in some men. It also actually reduces the semen volume over time. In some men, it can cause some changes in the mood and the energy level, and in a small proportion of men, it can also cause a little bit of enlargement in the breast tissues, and some of these can be painful. Tadalafil, this is the same class as Viagra, sildenafil. It is a cousin compound. We use it primarily for erectile dysfunction, but as a secondary effect, it also makes your urine flow better. So for men who cannot tolerate the previous two medications, or who do not want those medications, or at the same time they have some degree of erectile dysfunction, they want to try a daily dose of tadalafil, it is also possible. We give it as a low dose, a daily low dose, and that has been shown to help to both improve the urine flow and erectile dysfunction at the same time. But of course, the improvement in the urine flow will not be as impactful as the standard alpha blocker medication. Okay, so what to take? Usually, what guides me to give the medications are these two mainly. One is the prostate size. One is how bad is the symptoms, and do they have any other symptoms? Smaller prostate, usually just a single medication is enough. For larger prostates, a combination of treatment with alpha blocker and alpha reductase inhibitor, typically, for example, tamsulosin plus dutasteride. That has been shown in many studies to really have a good effect on the prostate by reducing the need for prostate surgery and improving the flow over time. But for small prostate, the 5-alpha reductase inhibitor doesn't seem to work, so usually we don't prescribe patients that medications for those with a smaller prostate. If there are other symptoms like erectile dysfunction, we can consider add-on ED medications as well, or for patients with overactive bladder, we can add on certain overactive bladder medications. There are a few available. But of course, with all these, you can end up with a lot of medications. Minimum 2, can be more, up to 3 or even 4. So when you have reached the stage where you need a lot of medications and symptoms don't seem to really work, and your chief problem is actually the prostate enlargement, then you may want to consider a prostate surgery. And when should you go for it? If you have in a few situations. The first one, if you start to have complications from severe or long-standing BPH, no questions asked. This one you should just go straight for surgery to protect your bladder and to protect your urinary tract. Otherwise, left alone, it can even start to affect your kidney due to the high blood pressure. In some patients, medicines don't work anymore. You may want to consider surgery. Or in some patients, it's a matter of personal choice and preferences. They don't want to be on medications, or they don't want to face the side effects of medications over the long term. Now, what are the complications of BPH that I was alluding to earlier? These are things like urine retention. No choice. I don't think once you hit a retention of urine, and you will need the catheter inserted, and if you fail the catheter removal, there's no point in trying medicines anymore. It's not going to work. Just go straight for surgery. Other situations like high remnant urine in the bladder, recurrent urinary tract infections in men, which can also include recurrent testicular infections. These are all related. Patient bladder stones, persistent blood in the urine, and if severe enough, there are signs that the kidney function is affected, then all of these problems, you should go straight for surgery, and the standard surgery, which is TURP, which I will discuss a little bit later on. Okay, so what are the types of BPH surgery? There are many. If you read around, if you just Google BPH surgery, you will see really a lot of options, and sometimes it is so overwhelming that you don't know which one you want to choose. So then, what surgery to choose? So maybe I will give you a guide of which can maybe help you in your decision. The first is TURP. This is the standard BPH surgery. To this date, it remains the gold standard surgery. It's been around for many years, so very long period, or rather, we know that it can last a long time after this surgery. We have a long duration of time to have the clinical evidence. So it results in the best improvements in your flow and your urinary symptoms, and it also reduces your remnant urine by the most. It is long lasting. We have evidence up to 22 years and it's still working. Of course, some of these patients will fail this treatment after a while because the prostate enlarged, but you can always go for another treatment, another surgery. So how it is done? Typically, when we do this, there are two energy settings that we use. We use electrical current to cut the prostate. It's either a monopolar electrical current or bipolar. In Singapore, as a standard, we use bipolar energy. We no longer use monopolar. In some parts of the world, they are still using monopolar energy. The technique of the surgery is the same, except with bipolar energy, because of how the current flows around the tissues, the risk of long-term complications is less. Okay, so how is it done? It's usually done under a half body anesthesia. You're awake. Some patients prefer to be fully knocked out because they don't want to remember anything. Then we put in a scope, a rigid instrument, metallic instrument into the bladder to see the prostate from inside. And then we use a cutting device to cut it out. So this is how it's going to look like from the scope. You can see the prostate, the two halves like hamburgers is squishing into the urinary tract. You can't see, you can imagine the flow is going to be really obstructed. Now we use a cutting device. Typically it is like a half circle in shape, the loop, to trim away the prostate tissues. And what we want to achieve is this, an open prostate channel that the urine can flow smoothly out from. Okay. And you can see in this example, the patient who comes in with a very poor flow, you see the top speed is really flat and it's taking a long time to pass urine. This is before surgery. After TURP, vast improvement in the flow. Now he's almost, if anything faster than this, there's going to be you can blow a hole in the toilet bowl already. And what is the patient going to experience? Check out the avoiding time. Before that, it's taking 78 seconds, 1.5 minutes to pass, to complete this urination of a similar volume. After surgery, he only takes 14 seconds. This is the normal time that you take. So imagine if you're a man, you're in a public toilet, you're standing there. That means the person next to you would have changed 3 to 4 times by the time you finish. So after surgery, you can expect to have a vast improvement in the flow, provided your bladder function is still good. It has not degenerated into the end-stage bladder yet. Now, if it is so good, why don't everybody go for it? Of course, as you can see, this is a cutting procedure. You are removing prostate tissues. You're creating a cavity. So there are bound to be some complications, possible complications, long-term side effects. Things like significant bleeding, recurrent urinary tract infection. Sometimes if you get the UTI, it can cause some retention also. Very rarely nowadays, especially if you use the bipolar energy, that we get the fluids and salt imbalance as a result of the surgery. In the long term, almost certainly you're going to have abnormal ejaculation. Some studies have quoted 65%, but I think it's going to be more than 80% chance. There is a risk of erectile dysfunction also, less with bipolar energy, about 2 to 3% with a monopolar energy device, because there is more heat damage to the surrounding tissue. Sometimes it can damage the erection nerves. It can be up to 10%. Long-term problems, other long-term problems will include things like a stricture and a bladder neck scarring. These are all scarring because of you leaving a cavity there. When it heals, there will be some scar tissue formation. And of course, there's a risk of incontinence also, although this is rare. There are variations of TURP, whether you enucleate the tissues or you vaporize the tissue. Enucleation has a more complete prostate tissue removal, and this results in a lower need for repeat surgery in the future. And there are also other techniques that utilize different energy types. We touched on bipolar and monopolar. There are also the use of plasma energy, and finally laser. And this is the kind of the trend nowadays, to use the laser to cut the prostate. Different types of laser: holmium, thulium, green light, depending on which centers that you go for. So I will touch a little bit about prostate laser surgery because it is this trend nowadays. Holmium, thulium, or green light. Apologies, a typo there. You can use it to enucleate the prostate or to vaporize the prostate, but the enucleation is a more thorough procedure. Things like you may have heard about HOLAP or even a 2-lap. This is a more thorough surgery for prostate tissue removal, but it requires a higher technical skills. There are some advantages over conventional TURP. There's less collateral heat damage, better bleeding control. As a result, the patient recovers faster with a shorter hospital stay. The technique essentially, or rather the principle is essentially the same. You want to remove the offending prostate tissue. It's just the use of a different energy, a different toy. So this is what you want to achieve for all of those surgery. This is the main effect. You want to convert a blocked channel like this on the left to one with an open channel by creating a cavity. Not possible to remove the entire prostate tissues because otherwise you're going to end up outside the prostate, which is dangerous. Then you can have urine leaking everywhere. So we always leave a rim of prostate tissues behind. Now, the next is the minimally invasive surgical treatment. This is a new and emerging field, has been around in the world for 5 to 7 years, but in Singapore, I think in the last 2 to 3 years, it has been quite popular as well. Good early and medium term results in terms of the flow improvement and quality of life improvements. But of course, you are not cutting the tissues, which means that you are trading the improvement in your urine flow with a better quality of life. For example, preservation of sexual functions. So the advantages are you avoid the TURP complication side effects, you preserve sexual functions. Usually we do these surgeries as a day case. Patients at higher risk of major surgeries can adopt this procedure as well. The disadvantage is that the long-term outcomes are not known because it's relatively new in the market. The first one I want to talk about is Resume, which is a water vapor convective treatment. It is delivered through a device quite similar to a bladder scope, where steam is released at the tip of the instrument at 9 second cycles. So this is a prostate that is enlarged. You can see the fluffy thing is supposed to represent enlarged prostate tissue. Put in the device, we inject a needle into it, and then we deliver steam at 9 seconds intervals. How many injections depend on the size of the prostate. And over time, because the steam will kill the prostate cells, and over time the body will resorb those dead cells, and that has the effect of opening the prostate channel. Of course, you can imagine it depends on the body reabsorbing those cells, which means that the effect takes a while before you see. Typically 1 month later, before a man starts to see effect, then it gets better and better, up to 4 to 6 months maximally. The advantage is there are no foreign bodies, foreign implants used in this case, which means if you go for prostate MRI, for example, in the future, it's not a problem. The only thing is the patient will need to have a catheter for about 1 to 2 weeks, depending on the prostate size after this treatment. Good preservation of sexual function. There are moderate improvements in the flow rates, in the symptoms control, and also the quality of life. The treatment lasts up to 5 years with a small proportion that requires another treatment. And there is some evidence that this results in prostate volume reduction up to 30% at 6 months. This is a case that I've done. This is before. You can see this man's flow is quite slow, taking a long time to pass. After treatment, this is 4.5 months later, you can see the flow has improved tremendously, kind of back to normal. The next one is Urolift. This works by putting a device quite similar to what you saw earlier on, but it's slightly different device. Also put in like a cystoscope, like a scope into the bladder, but you deploy little implants into the prostate to tension the blocking tissues apart so that you open up the channel. So in this case that I've done, you can see the prostate tissues are blocking at the sides. You apply implants there and you end up with an open channel like this. Quick procedure, does not need any catheterization after the procedure. And just a short video of how it works from the company website. You can see the implant is placed on each side, typically 4 implants for the standard size prostates to open up the channel. Good preservation of sexual functions as well, moderate improvements in the flows, the symptoms, and the quality of life. Very similar results to Resume, a durable improvement to 5 years. As compared to TURP, the experience is recovery experience is superior because there does not need to the patient does not require a catheter after the procedure. It is not as durable as the steam treatment, but the advantage is you do not need a catheter for this. You can go home without a catheter. Other options include things like a prosthetic temporary urethral stent. This is not available yet in Singapore, but in the US they are trying it out, and it is from an Israeli company. What happens is we insert a little umbrella-shaped stent into the prostate, open it up, leave it for 5 days. The pressure will kind of cause the prostate tissues to die and resulting in an open cavity. So 5 days later, remove the device, and the patient is supposed to be able to void or pass urine better after that. This is called ITIN. We don't have that yet. You may have also read about prostate artery embolization. So this is done by another group of specialists called the interventional radiologists, where for very large prostates, they inject tiny particles to block the blood supply to the prostate. This results in a shrinking of the prostate and thereby improvement in symptoms and flow rates. It is not our first line of minimally invasive treatments that we offer, though, because of a few limitations. It requires a pre-treatment angiogram scan, so that's additional x-rays, and which requires an injection of contrast into the bloodstream also. So because of that, it is not suitable with patients who have a chronic kidney disease. If the kidneys are not strong enough to take the dye compounds for the scan, then of course you can't go for this treatment. We cannot map out the vessels. For those patients who have other, for example, long-standing diabetes, a heart problem, stroke, some of them also have calcified or hardened blood vessels. In that situation, it is not possible to do this also because you cannot even pass a catheter into the bloodstream to inject the particles. But otherwise, it is not. It can be indicated for certain situations, especially those with large prostates, those who are very frail, too frail to go for any type of surgery. Many other options, technologies, aquablation, ProLeaf, temporary urethral stents, many others, but these are not rigorously studied yet. We do not have any good evidence to say that this is going to work for our patients yet. And there are several others also undergoing trial or in development. So that we need more studies to evaluate the effectiveness, safety, and treatment durability for these options before we want to offer them as a service for our patients. So how do you choose the surgery? It depends on the aim of the surgery. If the aim is to treat the complications of severe BPH and urinary retention, then it's either a TURP or a laser prostate surgery. Go for a big cavity so that you improve your flow and can last for a long time. If the aim is you just, you want to be off medications, the symptoms are not too bad, you just want some relief of your BPH symptoms, then you can go for any of the choices. All the choices are open for you. It's up to your personal preference. We can tweak a little bit based on your preference, which one is the suitable one for you. If you want to preserve your sexual functions, then really the minimally invasive options, I would offer them as the first line because it really works in helping to preserve your sexual functions. So the choice of surgery, nowadays, it is no longer the relief of the symptoms. There can be other domains also, like preservation of sexual function, avoiding complications, continence, and recovery experience. If your chief, let's say for an older man, 80 plus, his main concern is he just wants to have a relief of his symptoms. He just wants to have a better flow. Doesn't know the sexual function is not really relevant for them anymore, for him anymore. Then just go for TURP. This is the standard treatment, gold standard, lasts for a long time. If you don't mind paying a little bit more money to have a better recovery experience, less bleeding, avoid complications, then you can opt for laser surgery, either whole lab, 2 lab, or green light laser. If you are young and you are sexually active, you are still expanding your family and preserve your sexual function as much as possible. But of course, with a trade-off that the symptoms control will not be as good as the usual surgery, then you can consider the minimally invasive options. So some of these pathways you can discuss with your urologist. So as a take-home message, BPH is common. The treatment strategies include conservative treatment, medications, or surgery. The choice of surgery depends on how bad your symptoms are, whether there are complications or not, and of course on your preference. So if you have any of these problems, you can speak to your urologist, go and find a urologist to discuss all these options. Or if not, you can always find us at SGH by scanning the QR code. Okay, thank you for the talk. This is the end of my talk.
Thank you very much, Dr. Edwin, for that very, very comprehensive talk about BPH and all its treatment options. We will change gears now slightly to talk about raised prostate-specific antigen and the need for prostate biopsy. And for that, we have Dr. Tan Yu Kwang. Dr. Tan is currently the final year chief resident at the Department of Urology in SGH. He graduated from NUS School of Medicine in 2014 and has completed a master's degree in clinical investigation. He has a keen interest in uro-oncology and has published over 30 peer-reviewed manuscripts. He was selected to attend a prestigious Singapore Chief Residence course and graduated as one of the top candidates. May I invite Dr. Tan Yu Kwang, please?
Okay. Thank you, Yong-Sing, for that kind introduction. And a very good morning to everyone who is logged in to join us on this Saturday morning. And in this coming talk, I'll be sharing with you on diagnosis of prostate cancer, the PSA blood test, and prostate biopsy. And by the end of the session, I hope you have a better understanding of this condition. So in the next few moments, I'll be touching on how common is prostate cancer. What are the symptoms to look out for in prostate cancer? More importantly, I will share with you on what is PSA testing and also what it is not about. And last but not least, we will discuss the process of a prostate biopsy. So how common is prostate cancer exactly? Prostate cancer is the second most common cancer amongst men in Singapore after colorectal cancer, and it's also the fourth most common cause of death in Singaporean men, according to this report from the Singapore Cancer Registry in 2021. And globally, prostate cancer represents the most commonly occurring cancer in men, just surpassing lung cancer. And to put into perspective, 1 in 8 men will be diagnosed with prostate cancer in their lifetime. But before we get overly anxious and delve further into prostate cancer diagnosis, it's always important to understand the natural history of this condition. Unlike many other cancers, prostate cancer has a much slower growth velocity and progression rate, and does take several years to cause death. In the diagram on the right, you can see that prostate cancer death, highlighted in green, usually starts only 10 years after diagnosis. Therefore, in the elderly patients, they are more likely to die from other causes apart from prostate cancer. In this group of patients, the diagnosis of prostate cancer is often less important, and these patients are likely to die with rather than die from prostate cancer. But on the other hand, for the healthy middle-aged men with very good life expectancy, prostate cancer can be life-threatening. Therefore, early diagnosis and curative treatment should be the aim for this group of patients. So with the understanding on the prevalence and natural history of prostate cancer, I'm sure one of the top burning questions is, what are the symptoms of prostate cancer then? Unfortunately, there aren't many early warning signs of prostate cancer. The early growing tumor usually starts microscopically as a tiny spot in the prostate gland and does not distort the prostate enough to cause any symptoms. A lot of men relate urinary symptoms such as poor flow, hesitancy, incomplete emptying to prostate cancer, but the truth is more often than not, these are due to benign enlargement of the prostate gland, and I'm sure that you have heard from the previous speaker, Dr. Edwin, about the condition. Regardless, if you have any urinary symptoms, you should seek medical attention and your doctor will check on your prostate health. Having said so, prostate cancer can eventually cause symptoms, and this usually happens as the tumor grows much larger in the prostate gland. As seen here on the diagram on the right, as the tumor starts growing, it can distort the anatomy of the prostate gland and cause obstruction to your urine flow when it compresses on the urinary tract. It can also cause blood in the urine or pain in the pelvis as it invades surrounding organs. In the very late stages, it can give rise to bone pain and swelling in the legs. But the ultimate goal is not to find out when it's all too late. As with all cancers, we want to detect the cancer early at a time where it is still curable and can change the course of things. And very often, it starts with a simple blood test. So many of you might have heard or read about the blood test known as PSA, and this stands for the prostate-specific antigen. It's actually a molecule produced by the prostate cells, which helps to give semen its liquid texture. I've had many patients raising several assumptions regarding PSA readings and testing. In the next few slides, I will try to debunk some of these myths. So the first myth is PSA is a marker of cancer and it's only found when there is cancer. Now, this is false. Both normal and cancerous prostate cells will produce PSA, but in cancer, because the architecture of the prostate is disrupted, more PSA will leak into the bloodstream, causing a higher PSA reading. Another common misconception is that a raised PSA must mean that there is cancer. But this is again not true. It's important to note that PSA is imperfect as a marker of cancer on its own. While it is specific to the prostate gland, it's not specific to what is happening to the gland itself. And this remains the biggest limitation of PSA testing and screening. Many other conditions can cause the PSA level to be high. For example, benign enlargement of the prostate, inflammation of the prostate such as prostatitis, recent ejaculation, digital rectal examination, or even bicycle riding. More importantly, these conditions are not mutually exclusive. For instance, you might be having both prostate enlargement and prostate cancer concurrently. However, do not be entirely alarmed with an elevated PSA. Considering checking in with your GP or urologist, often a repeat PSA will be performed to see if it remains truly abnormal before considering further investigations to detect prostate cancer. Another comment that we hear from patients once in a while is that my father has an abnormal PSA, so it will happen to me. So while abnormal PSA reading by itself is not hereditary, prostate cancer can be. Fortunately, true hereditary prostate cancer is actually not common, but having a brother or father with prostate cancer may increase your risk by up to 3 times. Similarly, a strong family history of breast cancer can also increase your chance of getting prostate cancer due to related genetic mutations. So what are the other risk factors for prostate cancers? Apart from family history, prostate cancer is strongly associated with increasing age and is a cancer that primarily afflicts older men. As shown by this graph here, the chance of having prostate cancer rises sharply after the age of 50 years old. Therefore, routine PSA tests prior to 50 years old is not recommended. But at the end of the day, age and family history are things that we cannot change. What about things that we can change or do something about? What are the influence of lifestyle and environment on the risk of us having prostate cancer? Well, there is some evidence to suggest that advanced or more aggressive prostate cancer may be linked to metabolic syndrome, and it may help to tackle obesity and related conditions such as hypertension and diabetes by reducing your fat intake and increasing our activity level. Also, smoking has always been bad for our health. It was found that smokers were 20% more likely to develop prostate cancer and also dying from prostate cancer compared to non-smokers. Therefore, not starting or quitting smoking can help to reduce your risk of getting advanced prostate cancer. Again, another common question asked by my patients is regarding food and diet intake to reduce or prevent prostate cancer. Although you may have heard of some reports about certain food or health supplements that can help to reduce prostate cancer, to date, there's still no strong, robust evidence to recommend them in a proven preventive strategy. However, nonetheless, healthy eating and a healthy lifestyle can definitely do you no harm. So what are the other ways that we can find out more about the possibility of having prostate cancer? You might have heard about other blood tests, for instance, the Prostate Health Index, or PHI for short. This is a blood test also looking at PSA, but more specifically, it studies the other characteristics of the PSA molecules. It can provide a little bit more information about the probability of having prostate cancer when there's an elevated PSA value between 4 to 10. As shown in this table, a higher score may increase the risk of one having prostate cancer. So what else is there besides blood tests and more blood tests to detect prostate cancer? So because elevated PSA can be a harbinger of prostate cancer, for many years, your urologist will have offered an upfront prostate biopsy. And how this has been performed previously is as shown. A transrectal ultrasound probe is placed into the rectum, and tissues are taken by poking the needles through the rectal tissues into the prostate gland, which lies just in front of the rectum. However, the issues with this technique is the serious risk of infection because of the rectal route. Furthermore, the exact tumor location within the prostate gland cannot be identified, and this is somewhat considered a blind biopsy. Therefore, transrectal ultrasound prostate biopsy has largely fallen out of favor today. So today, there have been two important changes in the workup of an elevated PSA. The first game changer is MRI prostate. As an advanced imaging tool, it has provided us a high definition view of the prostate, much like a high definition TV. MRI prostate allows us to see prostate for the very first time. And here is the comparison between the transrectal ultrasound on the left and MRI prostate on the right. As you can see, the ultrasound scan can only vaguely mark out the prostate gland, but with the MRI scan, you can visualize at a much higher definition. Particularly, you can see the darkened areas as demonstrated by the red arrow, which represent areas of suspicion. Therefore, with MRI prostate, we can decide firstly, who needs biopsy? Mildly elevated PSA with normal MRI may avoid unnecessary biopsy. Secondly, this changes how we do biopsy today, because we can now potentially direct the biopsy needles at the MRI suspicious areas. And this leads me to the last segment of the talk. Indeed, the final step in diagnosing prostate cancer requires taking tissues from the prostate gland to confirm the presence of cancer cells. And this is also known as the prostate biopsy. And here we'll illustrate our SGH experience over the last 15 years on prostate biopsy. For the start, to reduce the infection risk associated with a transrectal prostate biopsy, we have now moved on to a transperineal prostate biopsy. This means that needles are inserted at the skin area below your scrotum, or what we call the perineum. This is a much cleaner route and reduce the infection risk to less than 0.1%. And the next game changer today is the incorporation of MRI images into our biopsy platforms to guide prostate biopsy based on the MRI results. Today, many platforms are available to provide this fusion technology. But I'm proud to say that SGH has been a forerunner in this technology more than 15 years ago. The current MRI ultrasound fusion robotic platform, Mona Lisa, represents the proprietary invention designed by our pioneer urologists here in SGH. And today, this current platform is being used in most restructured and private hospitals in Singapore and many urological centers internationally. And here I'll illustrate how this MRI ultrasound fusion technology works. So if you have an elevated PSA, you'll probably have an MRI scan done and show some areas of suspicion. So on the day of the surgery, we'll first perform an ultrasound of your prostate, following which the MRI images done previously will be imported and a 3D fusion model based on the real-time ultrasound and the imported MRI images will be performed. And this is the resultant composite 3D model after the fusion. And clearly, you can now see where the suspicious areas are located. Following which, the surgeon will use the platform to plan your biopsy. Targeted biopsy of the prostate will be performed by focusing on the supposed suspicious areas that are marked out by the MRI. Random biopsies from the rest of the prostate will be performed to exclude tumors that were not picked up by the MRI. And this is usually about 5%. So if time allows, this is a short 1-minute video explaining the process of a transperineal MRI targeted prostate biopsy.
On the day of biopsy, patient is placed under general anesthesia and in a lithotomy position. A transrectal ultrasound of the prostate is performed and a 3D model of the prostate is first generated with the Mona Lisa. The marked lesions, which have been saved as DICOM format, are then imported into Mona Lisa, the MRI prostate model, and that generated by real-time 3D ultrasound with the Mona Lisa at time of biopsy are then merged by non-linear regression to give a composite model. This allows the operator to see for the first time areas of suspicious tumor foci in the prostate. With an anatomical visual map, the biopsy is then planned with cores directed at the lesion as seen on the composite MRI ultrasound model in Mona Lisa. Targeted biopsies are planned and performed before saturation biopsies. After planning of the cores, the biopsies are then performed with the trajectory of the needle guided by the Mona Lisa. On the day.
So in a quick summary, it's clear that prostate biopsy has come a very long way over the years. And here in SGH, we have been involved in this journey for many years. The incorporation of MRI now allows patients to avoid unnecessary biopsy in normal MRI patients and also identify the more aggressive areas harboring cancer. The transperineal route has significantly reduced infection rates, making prostate biopsy a generally safe and routine procedure. And lastly, the robotic fusion platform has enabled us to pinpoint the tumor location to deliver that precision in prostate cancer diagnosis. And all of these pathways are available here in the SGH when you see us for elevated PSA. So this brings me to the end of the talk. And here are some of the take-home messages that I hope to share with everyone. Firstly, early prostate cancer often has no symptoms. Urinary symptoms, if present, are usually likely due to concomitant benign enlargement of the prostate gland. Age and family history are important risk factors, but so are your lifestyle modifications. PSA itself is still imperfect as a marker for prostate cancer, but it's often the starting point where further investigation will take place. Further imaging with MRI prostate can help you decide whether you truly need a prostate biopsy. And with transperineal MRI targeted prostate biopsy, today this represents the most accurate way of getting a prostate cancer diagnosis and represents the safest way of doing so. And ultimately, always speak to your urologist to provide the most accurate information about your condition. And with that, I've come to the end of my presentation. I'm happy to take any questions.
Okay, thank you very much, Dr. Tan, for that very informative talk. We have now come to the Q&A segment of our program. Actually, I know that We have answered over, I think, close to 100 questions already on the Q&A chat box. May I invite all the speakers to come on with us now, and we'll help to answer any last remaining questions that you may have. So a reminder to just enter them to the chat box, and we'll try to address them as much as possible. So maybe Dr. Tan, maybe first one for you. How often do we need to do PSA?
Hey, thanks, Yongjin. That's a very good question. So usually, I think if you have a normal PSA, most of the guidelines will say that you can consider a PSA check every 3 to 4 years subsequently. There are some international guidelines that say your very first baseline PSA level at your age adjusted will also tell you when do you need a PSA test later on. So for example, if your PSA is actually less than 1 at the age of 40 years old, or less than 2 by the age of 60 years old, you can actually defer the next PSA screening to 8 years later instead of the usual 3 to 4 years.
Okay, and then to follow on one, what are common side effects of a prostate biopsy? I think you covered some of these just now. Maybe you quickly answer this.
So I think so today we are mostly doing our prostate biopsy through the transperineal route, and this is under a short general anesthesia of 15 minutes. The common side effects, firstly, you may get a little bit of blood in the urine or in your ejaculate for usually about 2 to 3 weeks, which generally improve over time. You get a little bit of perineum bruising because that's where the needles come through. Infection rates are usually not common nowadays. We don't routinely prescribe antibiotics anymore because the infection rate is less than 0.1%. I think one thing to highlight is that because we are trying to increase the accuracy of the detecting prostate cancer, we tend to take a lot more tissues today compared to the older days where we do a transrectal biopsy. And for a prostate volume of 30 to 40 mils, you will be expecting that the surgeon will take almost close to 30 to 40 tissues from it. So I will always tell my patient that there's always a small risk of urinary retention, means that you cannot pass urine. This occurs in about 5 to 10% of patients, but this is transient. So usually we'll get you to pass urine after the operation, make sure you can void well. But if the case that you cannot empty your bladder, then you will need a urinary catheterization for about 3 to 5 days. We'll see you later in the clinic, we'll take it out for you. And most of them do not go into long-term retention for that matter.
Okay, thank you. Maybe we switch to Dr. Edwin. Dr. Edwin, I think there are some questions about BPH medications. Maybe you can take them. Does taking alpha inhibitors addictive? I mean, I don't think so. With any side effects like dementia, alpha blockers, I think.
I saw quite a few questions on BPH medications. Collectively, I will answer them. But let me just read it out, the questions also, so everybody can benefit. So some people are asking, does alpha blockers, are they addictive? Number one, does it have side effects like dementia? Do you have to take it for life? And these are the main things. Okay, so first of all, it is not an addictive medications to take, not like we take some and then you need to take more to overcome the dependency. It doesn't work like that. So no, it's not addictive. Second thing, most patients have to take it for life because it does not reduce the size of your prostate. It merely let you pass out the urine smoother. In that way, it can protect your bladder. So you have to take it over the long term if you do not go for surgeries or any other treatment. The last one, for patients who are on alpha blocker plus the 5 alpha reductase inhibitors, for those patients, sometimes the prostate can reduce in size enough to the point that you can switch to only one medications after you have been on treatment for a while, rather than keeping on 2 for life. And no, it does not cause the dementia. That's not a side effect of this group of medications.
Okay, what about this one? What is the typical Uroflow test flow rate that the patient would need to consider surgery as an option for?
Okay, in general, we take Uroflow is affected by many things. You can have the top speed, we call it the maximal flow, can have many things can affect it. For example, if when you do the test, you don't pass enough into the machine, then you can have a slower speed. And then when you pass a good enough amount, then that is more representative of the usual speed. Generally, we take 10 mils per second as the cutoff. 10 mils per minute as a cutoff. But some patients, does not necessarily means that you need a surgery because the flow is affected by your bladder function also. If you are someone who have some degree of what we call underactive bladder, or your bladder has taken enough damage, sometimes the flow, it can be slow, but it does not necessarily mean you need to go for surgery at that time. But yes, if your problem is predominantly an enlarged prostate and the flow is 10 or less, then I would, and you're on medications, and it's still without much effect, then I would recommend a surgery for you.
Okay, maybe to Dr. Lim, what is the benefit of Kegel's exercise? I think you've covered a little bit about this in your talk.
Yeah, so Kegel exercise mainly is used for people who have like pelvic floor muscle weakness. It's not meant for everybody, depending on what the condition is. There is a benefit if there's regular and sustained practice of this correct technique of Kegel exercise. So this will really depend on what your main complaint is and which type of lower urinary tract symptom you have. But there is benefit mainly for those mild to moderate severe pelvic floor weakness.
Thank you. What about, there's a question on what is the consequence or problem with bladder thickening? I was told to hold urine till I feel my bladder is full, then go toilet. Is this good and true?
Yeah, so that will depend. I mean, bladder wall thickening is not something that we should see. Generally, we do see it in elderly patients or patients who have had a habit of holding their urine over some time. This can be due to a variety of reasons. Sometimes chronic infection, inflammation can give a reactive change. Other more common ones would be if the bladder has been constantly overstretched by you holding your urine for extended periods of time. I mean, the most common reason would be if they're very busy at work, the toilet is not very clean, they're not comfortable, they don't want to go, or they're too lazy to get up at night and they just want to sleep through. So overstretching of the bladder constantly can lead to a bit of changes in the bladder muscle, which will then lead to thickening. And the main effect they will see is sometimes after it's been stretched too many times for too long, the bladder muscle becomes not effective in trying to contract, and therefore you can't contract enough to pee out the volume of urine that you have. Yeah, so it's not something that we want to see.
Okay, maybe I think we have time for a last question, maybe for Dr. Edwin. I'm taking tamsulosin hydrochloride. Does it cause breast inflammation?
No. So tamsulosin generally do not cause any breast inflammation or breast enlargement. Some patients who also take the 5-alpha reductase like finasteride or dutasteride, a small proportion of them can have a bit of breast inflammation, painful breast enlargement, but not tamsulosin.
Okay, and I think with that, we have come to the end of the English seminar. We have actually gone past our allocated time. On behalf of our head of department and the rest of the urology department, I'd like to thank everyone for spending your precious Saturday morning with us. We also thank our speakers, 3 of them, very wonderful speakers, and the Patient Liaison Service Department, SGH, for their hard work in bringing this seminar together. We hope that we have managed to give you a better idea of some of the urological ailments that commonly trouble patients. And for those who have interested, we have a Mandarin seminar coming up after this at 11 a.m. and we will cover topics about stone diseases and incontinence. A very gentle reminder that we are also raising funds to support urological education and cutting-edge research here in SGH. Please give generously to a very good cause to allow us to better help patients with urological conditions. And also, if you require a consultation with our urologist, please head to the SGH website where you can actually book an appointment and request for a consultation with one of our urologists, or you can of course also seek your family doctor's opinion or the polyclinic's doctor's opinion. Thank you once again for helping and joining our seminar today, and we wish you a very, very pleasant afternoon, and we hope you have a very good weekend. Goodbye.